have liftoff.
Hello, hello.
Now we're facing into the void. Hi, everybody. Welcome back to another episode of Getting That Medical Degree. What's on today's dinner?
Today's
Renal
dinner,
disease.
Kenny's dinner.
That sounds like a horrible. I don't know why I said that.
It does sound terrible, but maybe
Because
the idea.
I guess we're learning about renal disease for the Naplex. Is it
Yes.
Naplex or Naplex?
Everyone says it differently. Some people say Naplex, some people say Naplex. So, eh,
Okay.
I don't think it's the right way to say it. Anyways, this is for the pharmacy exam that we graduate pharmacy school have to take to get their licensing. So, this is going to be a review for myself because I'm studying for it, but also for you, review for you guys too. Here we go. So, again, are some of the parts of the kidney. The afferent arteriole delivers blood to the glomerulus. I don't know if he'll actually ask you that or not. That's just a tidbit of knowledge that RX Prep
No, I did
emphasized.
that's definitely gonna come.
You never know. They could throw that in there for you. But something they might ask you is, where does aldosterone work? So aldosterone actually works in a distal convoluted tubule, or DC, in the collecting duct, or collecting tubule, which is why I put C there. And this increases sodium and water absorption and decreases the potassium reabsorption. The DCT, or distal convoluted tubule, or thiazide diuretics work. This will probably be a question in your test somewhere. It inhibits the sodium chloride pump. Ascending loop is where loop diuretics work. They inhibit the sodium potassium pump. And the proximal tubule is or SGO2 inhibitors work. That's your flozins. These are your diabetics. Diabetic. Those are pretty common questions you get asked in school and on practice tests. So, drugs that injure your kidneys. But yeah, I separate this up with two in each line because that's kind of how my brain worked for remembering this. So an acronym I made up for is AAC, CLN, and T. I don't know why. It just seemed like it made sense to me. But aminoglycosides, amphotericin B, cisplat, and cyclospore. Loop diuretics and NSAIDs, tacrolimus, and zinc. Pretty much half of these are pretty easy to know. Loop diuretics you might forget. Also NSAIDs, sometimes people forget that one as well. Vancomycin, yeah, it's antibiotic, so same with the aminoglycosides. Calculating creatinine clearance. This is a common calculation you have on your tests. So they'd like to combine multiple calculations with this thing called ideal body weight, which is on the next slide, I think. Anyways, this calculation is 140 minus your age. That's going to be times by ideal body weight. Divide that by 72 times serum creatinine. And if they're female, times by 0.85. That's another key point they get you out in the exam. If you're just in a rush in the equation, and if it times by 0.85, you're going to get the completely wrong answer, and you're going to be crying. This is one you need to commit to memory as soon as possible, because you'll be seeing it again and again, especially if you're still in school. So ideal body weight for men is 50 kgs plus 2.3 kgs for each inch over 5 feet. And women's the same thing, but it's 45.5. Adjusted body weight isn't used as much, but it is important to the equation. So it's ideal body weight plus 0.4 times the quantity of the adjusted body weight minus the actual body weight minus the ideal body weight. And this is mostly used as ideal body weight. The actual body weight's a little high of the ideal body weight. So just another way to adjust it, but might not need that bottom equation, but ideal body weight you'll definitely need. Serum creatinine in the normal range is between 0.6 and 1.2. If you just remember the 0.6, you just times that by 2, you get 1.2. That's kind of easy to remember. Mitchell can remember that, right, Mitchell?
Yeah, I can definitely remember that.
So ACE inhibitors, which is ACEI, and ARBs. So ACE inhibitors are like lisinopril, and ARBs are like losartan, which are common hypertension medications. It can actually increase the serum creatinine by about 30%, but do not stop therapy treatment because it's kind of like a pseudo bump. Sometimes it can lead to a more serious issue, but most times it's like a pseudo. You don't want to stop their hypertension treatment because you see a 30% increase, which is a big increase. If you see even a little bit increase, you start worrying about it. But ACE inhibitors and ARBs can increase it by 30%, not stop their treatment. That's a key point to know. So, next up is GFR. GFR just is a quick way doctors can tell you how well the kidney is working, and this is how some of the drug dosing is based off of too. The G1 or group 1 is normal. That's greater than 90 GFR. That's hopefully what Mitchell's kidneys are working at right now.
What?
Hopefully Mitchell's kidneys are have greater than 90 GFR. Hopefully. G2 is mild at 60 to 89. Some of these are kind of hard to remember. G3A is mild to moderate. That's 45 to 59. G3B is moderate to severe. That's 30 to 44. G4, which is group 4, is severe. It's 15 to 29. G5 or group 5 is kidney failure. It's less than 15. So less than 15 is pretty bad. 15 to 29 is still pretty bad. The thing with kidneys is like once your kidney function goes down, there's really no coming back from it. So it's really important to take care of your kidneys. Because once you start going down the slope, you can't go back up. So next up, you have albumin urea. Basically, you just need to memorize the range for moderate, which is 3 to 30. If you're less than 3, you're normal. If you're greater than 30, you're severe. So knowing 3 to 30 is easy. You know that. And then you know less than 3, you're normal. Greater than 30, you're severe. Easy, done. And if this is present, you probably want to be on an ACE inhibitor that prevents progression of chronic kidney disease or a CKD. So ACE inhibitors are kidney protective. You guys probably know most diabetics are on them. Something to know. So 3 to 30, know that. If you're less than 3, you're normal. Greater than 30, you're severe. Something to know. Common medications that need dose reduction or the dose extended. Anti-infectives, cardiovascular drugs, GI drugs such as H2RAs, biphosphonates, and lithium. Some more specific ones that are contraindicated if the creatinine clearance is too low. If the creatinine clearance is less than 60, you can't use macrobid. Less than 50, you can't use TDF, voriconazole IV. And less than 30 is usually the main cutoff for contraindications. So like NSAIDs, dabigatran, Xarelto, metformin, SGLT2 inhibitors, and the list goes on. Usually less than 30 is usually where most drugs are cut off if they're renally. Leave that up for you guys to look at for a second. Now, when you have kidney issues, you have other issues that can happen too. So your phosphate can be a little too high, so you're not eliminating electrolytes. So if your phosphorus is high, you go into a thing called hyperphosphatemia. To treat this, you can use phosphate binders. It's like aluminum hydroxide. This is usually used about 3 times a day, TID, with meals, and can cause dialysis dementia. Usually use a calcium-based first line, so it's like calcium acetate or calcium carbonate. But for some odd reason, your patient can't use aluminum or calcium phosphate binders. I don't really know a reason for this, other than maybe allergic reaction to one of these things, which is probably pretty rare. There's some alternatives though, such as sucroferric, ferric citrate, lithium carbonate. And the main side effects from these is like nausea, vomiting, constipation. You also have sevelamer, which can be carbonate form is Revela. The hydrochloric acid is Renagel. And side effects from this is nausea, vomiting, diarrhea, and it can lower the cholesterol. Really, maybe you'll be asked on the brand name here, like sevelamer, the carbonates Revela. I honestly don't know what to ask you other than like when you use a phosphate binder, this and picking the correct one. Knowing the calcium's first line. Now, vitamin D deficiency is also an issue. kidneys as well. And this you can use calcitrol or rocalcitrol or calcifidol, which is morality, and some other ones as calcimetics, the main side effects hypocalcemia. Also, you can have anemia as well, which you use a erythropoietin stimulating agent or ESA. We don't really use these unless the hemoglobin is less than 10, and you usually stop the it once it goes over 10 anyways. So, last up we have hyperkalemia. So hyperkalemia is when your potassium's a little too high. This is bad because this can lead to arrhythmias in your heart, which is why the first step in treating hyperkalemia is using calcium gluconate, which stabilizes the heart to prevent arrhythmias. And after that, you want to shift the potassium into the cells. So use insulin, dextrose, bicarb, or albuterol. And I might be saying why albuterol. Well, albuterol actually pushes the potassium into the cell. Kind of interesting. The reason why dextrose is here is if you're giving someone insulin to put potassium into the cell, you need to give them dextrose so they don't go in hypoglycemic. So you see that on a test choice, don't pick insulin by itself. It better have dextrose with it. Okay. To remove potassium from the body, you can use Lasix or furosemide. It's a loop diuretic. Sodium polyestrine sulfonate. Petromer in hemodialysis. Polyestrine can bind to other meds, so you need to make sure you know that. And patiromer can cause hypomagnesemia. That's a warning. And you also want to separate by other drugs by 3 hours. Hope you guys learned something from this video. I try to keep the pretty short and keep the main ideas and explain them at least as possible. Did you learn something, Mitchell?
Thank you. Yeah, yeah. Thank you guys so much for tuning in to another episode of Burning with Zach.
Please like, comment, and
um,
subscribe, and see you next video, guys.
yeah.